Hello, and welcome to the next edition in the glaucoma lecture series. Today's topic is going to be angle closure glaucoma without pupillary block. This is Dr. Ramesh Ayyala from Tulane School of Medicine, and this talk is presented by MediTred, a leader in online training and education. If you remember, last week we had a talk on primary angle closure glaucoma. Today we're going to discuss angle closure without pupillary block mechanism. An example that we can give here, let me see if I can open up my, oh, okay, here. Alrighty, so let's go to our drawing board. So I want to go through the mechanisms for you first, and hopefully by the time I'm done with with these drawings, you will understand the basic mechanisms that are involved in these different kinds of glaucoma. And then we'll go through the actual topics involved, and then we'll close off with some high yield, like my residents say, material that will be helpful for your exams. So the primary angle closure without pupillary block, the primary example that we talk about here is Plateau iris. So what are we talking about when we say Plateau iris? Here is the cornea. Here is your iris and the lens underneath, right? And you have the ciliary body. Okay, so this is a nice angle that's about 30 degrees or so, 30, 40 degrees or so open. So imagine on the other side, there is a situation where the iris, as it comes close to the root, is pushed up and is close to the root of close to the trabecular meshwork with a little bump for whatever reason. If such a situation were to exist, even though the chamber depth is normal, as the iris comes close to the root of the iris, it's being pushed anteriorly, and so this angle here is compromised, and this compromisation is going to get worse when the pupil is dilated. When pupil is dilated in this setup, there is bunching of the iris against the angle structures, leading to closure of the trabecular meshwork and increase in the intraocular pressure, right? So this is a situation that's called as Plateau iris. There are three criteria that you need to satisfy for Plateau iris. So one is that the chamber has to be deep or normal depth. Two, the iris is flat. And three, the insertion of the root of the iris or close to it is where the iris is pushed anteriorly, causing this potential for angle closure. And the most common cause for this anterior push of the root of the iris is the anterior rotation of the ciliary processes. This anterior position of the ciliary processes will lead to pushing forwards of the iris, root of the iris. That in turn is going to close the trabecular meshwork. Okay, so this is the most common reason why you have Plateau iris, anterior rotation of the ciliary process. Remember that. Okay, so based on this classification, people have classified the other reasons why you can have this or the other things that are associated with this. As you can imagine, if there is an abnormality in which, let's blow up this angle a little bit. Here is your trabecular meshwork, here is your Schlem's canal. Okay, normally the iris should be inserted into the ciliary body right about here. Okay, but if the ciliary process is pushing it like this, you have a bump, right? Which is the situation that we discussed here. On the other hand, imagine a situation where the iris is inserted into the trabecular meshwork itself. And this could be in three gradations. It could be either at the base of the trabecular meshwork, in the middle portion of the trabecular meshwork, or anterior to the trabecular meshwork. In all these three situations, as you can imagine, the angle is compromised, and anytime you dilate the pupil or the pupil is mid-dilated, you can have bunching of the iris in this location, leading to obstruction to the trabecular meshwork, causing the pressure to go up. So based on where the anatomy falls, either you call this as plateau iris configuration, where the root is kind of pushed anteriorly, compromising the trabecular meshwork anatomy. But in association with that, there could be also a relative pupillary block mechanism that will worsen the situation. So a plateau iris configuration is where the antechamber is deep, the root is a little compromised. In association with the relative pupillary block mechanism, you do your standard PI and it resolves the attack. Whereas plateau iris syndrome is where, in spite of you doing the PI, the attack does not resolve. And in these cases, clearly, one of these other two mechanisms are at play, where the ciliary process is pushing this root of the iris anteriorly, and the root of the iris itself may be displaced more anteriorly, meaning into the trabecular meshwork itself. Consequently, because of these two anatomical abnormalities, you will have in a dilated pupillary situation, crowding of the angle leading to an attack of angle structures. Now that you know the pathophysiology of this, you can design your own treatment, right? So when you see this kind of a setup where the angle is open, I mean, the antechamber is deep, the iris is flat. However, the patient, when you do gonioscopy, you will see there's crowding of the angle structures. You know that this is plateau iris. And the treatment, first treatment is to do a PI. That didn't work. You may want to peel this iris away from the angle structures by doing argon laser iridoplasty, which we discussed in our previous lectures. So argon laser iridoplasty will hopefully peel this iris away from the angle structures. If that doesn't work, one can conceive removing this lens, even if it's a clear lens extraction. I tend to take this lens out as the next step in treatment to decompress this space here. And at the same time, you may want to, this anteriorly rotated ciliary processes, you want to move them away from the root of the iris, and this can be achieved by applying endo laser to the ciliary process to shrink it away. So instead of facing anteriorly, it moves away and faces posteriorly, thus decreasing the anterior push mechanism. So that's the plateau iris syndrome for you. Let's move on to the next mechanism that we're going to discuss today. Angle closure secondary to anterior pole. So there are certain situations where this angle, again, let's go back to a drawing. My corneal drawing is getting worse as the talk goes on here. Okay, so let's see. Here is the iris, here is the angle, and here is the cornea. So imagine a condition where the iris is pulled onto the angle, either the angle structures or beyond onto the cornea, then the angle is obstructed. Okay, here is the normal angle. It's nice and open, whereas here there's some fibrovascular membrane is growing onto the trabecular meshwork or onto the cornea itself, or descending from the cornea, causing an obstruction of the underlying trabecular meshwork Schlemm's canal complex. And so the patient ends up with sudden increase in intraocular pressure. Now, this can happen in two common examples that we have: neovascular glaucoma, wherein there is this wherein they have this fibrovascular membrane that grows from the surface of the iris onto the trabecular meshwork and stops at the Schwalbe's line. Or on the other hand, you have conditions such as ice, where you have abnormal corneal endothelium that normally stops short at the Schwalbe's line. In this case, continues to proliferate down onto the iris, okay? And in the process, it blocks the trabecular meshwork. Now, the PAS, the difference in the PAS between neovascular glaucoma and the eye syndrome, as you note here, the PAS is stopping at the Schwalbe's line, whereas here the PAS is riding high onto the cornea. So is this more anterior insertion of the PAS, whereas here in neovascular glaucoma, you see that it's stopping short at the Schwalbe's line. So that gives you this understanding of this mechanism of this angle closure secondary to anterior pole. Let's go on to the third mechanism that we're going to discuss today: angle closure secondary to posterior push. Okay, let's see if we can get this straightened out. Here is the eye. Here is the cornea. Here's your iris. It's kind of difficult to draw with this. And here's your retina. And in between, you have your lens. Let's give some structure to the cornea here. Okay, now at least you can see that there is a good structure here. Now, when we talk about posterior push mechanism, we're talking about a force from the vitreous cavity pushing the lens. Consequently, the lens is plastered against the iris, which in turn will push the entire lens iris configuration into the anterior chamber and leading to closure of the angle structures. So if you can bear with me, I'll show you how this will look. Any pathology that does this posterior push mechanism will ultimately result in something like this. The push is strong enough, it can collapse the anterior chamber completely. But as you can see, the angle is compromised, the drainage pathways are compromised, and consequently the pressure is going to go up. So what are the simple concept, right? So what are the things that can give you a posterior push so as to collapse the anterior chamber, consequently compromising the drainage angles? You can think of tumors. Okay, choroidal melanoma that's breaking into the vitreous, retinoblastomas that's breaking into the vitreous, occupying the entire posterior chamber, iris cysts or ciliary body tumors that can accomplish the same thing. Suprachoroidal bleeding into the suprachoroidal space. So if you have blood in this area, again, massive suprachoroidal hemorrhage, it will squeeze the vitreous anteriorly, and it's going to push the vitreous, push the lens iris diaphragm anteriorly, right? Or you can think of conditions such as PRP and panretinal photocoagulation or central retinal vein occlusion. But in all of those situations, there will be swelling of the ciliary body itself, and this swollen ciliary body is the reason why there is anterior rotation of the ciliary processes, consequently pushing the lens iris diaphragm anteriorly and narrowing of the angle. Okay, but the most complex among all of this is what we call as malignant glaucoma. It's a rare syndrome, but when you do see it, there's no mistaking it. And so let's try and understand malignant glaucoma, because the other concepts here for the push mechanism, such as the tumors, the bleeding, the swelling, all of those are easy to understand. And the treatment for all of those is to attack the cause. Suprachoroidal hemorrhage, you got to drain the blood. If there's swelling following CRVO or PRP, you can use some steroids to decrease the ciliary body swelling. If you have tumors or cyst, then try and attack the tumor or the cyst to resolve this angle closure. Whereas malignant glaucoma is a different entity altogether. In malignant glaucoma, you have shallow anterior chamber right across the board. Okay, the entire chamber becomes shallow. You have a lens iris diaphragm that's pushed forwards. You have a vitreous that appears to be more hydrated, causing this to occur. As to exactly what triggers this is still a source of debate. But let me see if I can explain to you how this is supposed to work. You have the anterior hyaloid phase. Let me see if I can. There's no eraser to this marker. Is this the eraser? Okay, well, let me see if I can explain this to you. So you have the, let me draw another drawing on the side here. Typically, malignant glaucoma occurs in a hyperopic eye. Okay, so I'm going to draw a smaller diagram here. Already. So the lens is slightly bigger in a smaller eye, which is a hyperopic eye, and these are the eyes that are prone for malignant glaucoma. You have a hyaloid face, an anterior hyaloid face of the vitreous that's stretching out against the ciliary body. But normally there is a small space between the anterior hyaloid face and the ciliary processes. Okay, this space. Remember this. There is a small empty space right there. Now, what happens is this: the initiating factor in majority of the cases of malignant glaucoma is a glaucoma filtration procedure. So you do a trabeculectomy in an eye such as this and let fluid to exit out. When you do this, you're going to set up a sequence of events. The anterior chamber is going to become shallow, right? So the lens moves forwards. Along with that, the anterior hyaloid also moves forwards, coming in close contact with the ciliary process. And it's believed that these eyes may have some anatomical abnormality which allows for this peripheral anterior hyaloid face of the vitreous to come close to and get attached to the ciliary process in such a way that the ciliary process now is secreting the aqueous into the vitreous, thus hydrating the vitreous. Okay, once the vitreous gets more and more hydrated, it's going to push the lens iris diaphragm anteriorly, leading to this kind of a setup where the anterior chamber is collapsed, the trabecular meshwork is compromised, and the pressure gradually creeps up. And there are other factors that are associated here. There is mounting evidence that the choroid plays a role in the initiation. Nobody knows if this is a starting point or it's part of the complex anatomical changes that take place. But certainly there is increased volume in the choroid, the thickening of the choroid that people are able to document in these cases using using ultrasound and OCT examinations. And consequently, if the volume of the choroid is increased, it also is going to push the vitreous anteriorly, which may explain forward motion of the vitreous base, again, incorporating the anterior hyaloid close to the ciliary process in such a way that the ciliary process aqueous secretion is pushed into the vitreous rather than into the posterior chamber, leading to the same mechanism. So since we do know, clinically speaking, that doing a glaucoma filtration procedure is the trigger in majority of these cases, we have to believe that anatomically predisposed eye, you do a glaucoma filtration procedure, let some of the aqueous out of the anterior chamber, setting the stage for a shallow chamber, which in turn would mean that the lens is going to move anteriorly, giving an opportunity for the anterior hyaloid, peripheral portion of the anterior hyaloid to move anteriorly, coming in close contact with the ciliary process in such a way that the ciliary process now secretes aqueous into the vitreous, increasing the hydration of the vitreous. At some point, the choroidal volume also increases between the hydrated vitreous and increased volume of the choroid. You have a anterior push mechanism leading to shallow chambers and angle closure. Two other critical things that you need to rule out in the differential diagnosis is the absence of fluid or blood in the suprachoroidal space, which can also push anteriorly and cause shallowing of the anterior chamber following glaucoma filtration procedure. So, as long as the retina is flat, anterior chamber is collapsed, pressure is gradually creeping up. Following glaucoma filtration surgery, you are safe to make a diagnosis of malignant glaucoma. Okay, alrighty. So I hope you have a good start at understanding the pathophysiology of these different mechanisms that we're going to discuss now. So primary angle closure glaucoma without pupillary block. Barkin observed that 20% of the eyes angle closure glaucoma had deep anterior chamber, no iris bombay, and no pupillary block. And further down, Schaefer and Chandler called this as Plateau iris, and Wand et al. Classified it into iris configuration, Plateau iris configuration, and Plateau iris syndrome. Here are some examples of patients. Here is a patient that I treated here at Tulane with Plateau iris syndrome. You can see that the iris is flat. This is a pupillary block mechanism as opposed to Plateau iris. You can see the convexity of the iris. Okay, whereas here the iris is flat. And here is an ultrasound picture that I found on the internet, and I would like to acknowledge that NYEEI Ocular Imaging Center for helping in this teaching process. So you can see actually that the iris is pushed, and the root of the iris is pushed anteriorly, that compromising the trabecular meshwork. And here is a schematic of the same, showing different insertions of the root of the iris into the trabecular meshwork that will lead to compromised drainage pathways and narrowing of the angles. So what is the difference between configuration and syndrome? Angle closure glaucoma in an eye with normal central AC depth and flat iris plane. On gonioscopy, you will see that the iris is flat. There is a posterior turn followed and it's inserted into the anterior portion of the ciliary body. They have a narrow angle recess, and there is a potential for angle closure. When you dilate these eyes, pupillary dilation, you will see peripheral iris bunching and leading to angle crowding and pressure spikes. Now, these patients respond to doing a peripheral iridotomy using the YAG laser, as opposed to Plateau iris syndrome patients who have similar Plateau iris configuration, except that the angle closure occurs despite peripheral iridotomy. So in syndrome, the iridotomy does not treat the angle closure. They have anterior iris insertion in syndrome patients. Ciliary body processes have a forward or anterior rotation, and this is supposed to be the most common association with Plateau iris syndrome, typically seen in young patients between 30 and 40 years of age. There is no sex predilection in this syndrome. These attacks can occur spontaneously or after pharmacological dilation. Repeat attacks can lead to peripheral anterosynovial formation, leading to chronic angle closure and a permanent increase in the intraocular pressure. So the treatment, as I said in the initial phases, the first thing that you want to do is to try a peripheral iridotomy with the YAG laser. Configuration will resolve, whereas in Plateau iris syndrome patients, the PI does not resolve the attacks. You can try pilocarpine in combination with the peripheral argon laser iridoplasty, and this does work very well in some of these patients. If the argon laser iridoplasty in combination with pilocarpine does not resolve these attacks, the next step that you need to do is a combination of removal of the lens, even if it's a clear lens. Do not hesitate taking this lens out, followed by ECP to shrink the ciliary processes. We'll discuss the techniques involved in endocyclophotocoagulation to shrink the ciliary process in later videos, but I want you to understand the steps involved in managing these patients. So the first thing that you want to do is to relieve the relative pupillary block that may be associated with Plateau iris by doing a PI, and this may break the attack, especially if the patient has a Plateau iris configuration. This does not help, then do a combination of pilocarpine with argon laser iridoplasty. And if that does not resolve the episodes, then move to the last step, which is removal of the lens and ECP to shrink the ciliary process. This combination usually works in almost all the patients. There are these occasional patients where you may have to resort to creating unichamber. I think it's Ike Ahmed who coined the word unichamber, where you want to take the lens out and do a vitrectomy and leave a communication between the anterior and the posterior chamber to resolve these episodes from happening. Let's move on to the third mechanism, anterior, the second mechanism, the anterior pulling mechanism. Neovascular glaucoma and eye syndrome patients, inflammatory or non-inflammatory membrane contracts to pull iris over the trabecular meshwork in these situations. So neovascular glaucoma, you have a fibrovascular membrane on the iris and angle leading to peripheral anterior synovial formation and a sudden increase in the intraocular pressure, always secondary to retinal ischemia. It was first described in 1866 following a central retinal vein occlusion. The etiology of neovascular glaucoma, all of you probably are aware of the top three: diabetes, central retinal vein occlusion, central retinal artery occlusion, branch vein, branch arterial occlusions. And remember, diabetes is the number one cause in the category of ocular vascular disorders, and carotid arterial occlusions disorders are the number one cause in systemic vascular disorders that can lead to retinal ischemia and neovascular glaucoma. All these variety of diseases, they all can lead to retinal ischemia, which subsequently can lead to neovascular glaucoma. So the retinal ischemia, as you know, leads to VEGF or vascular endothelial growth factor release, which in turn leads to new vessel formation along with fibrovascular membrane formation, which leads to the PAS or peripheral anterior synovial formation and obstruction of the angle structures, leading to sudden increase in the intraocular pressure. Diabetes is the most common cause, as I just mentioned, 1/3 of all cases, where especially seen in patients post-vitrectomy in aphakic eyes, which gives the opportunity for the VEGF to migrate onto the surface of the iris to cause rubiosis. Rubiosis iris is seen in 1 to 17% in all diabetic patients, and 33 to 64% in patients with proliferative diabetic retinopathy. It's more common in proliferative diabetic retinopathy and ischemic retinopathy, neovascular glaucoma. And neovascular glaucoma is less common among patients who had treatment with panretinal photocoagulation, which decreases the production of the vascular endothelial growth factor. CRVO is the second most common cause for neovascular glaucoma. 30% of all central retinal vein occlusion patients can develop neovascular glaucoma. 60 to 80% among ischemic central retinal vein occlusion, as is seen in this particular example here, or 0 to 4% among non-ischemic central retinal vein occlusion. So doing a fluorescein angiogram at presentation to classify the patients into ischemic and non-ischemic is important when you see a patient with CRVO. If the patient is ischemic CRVO, then most retinal surgeons, I think, proceed with the PRP or panretinal photocoagulation in combination with one of those anti-VEGF medications nowadays. So typically in a non-treated eye, especially in ischemic CRVO, 3 months after the event, you will see neovascular glaucoma development, and that's what the reason why it's called 100-day glaucoma. Now, also remember one other fact that 15% of the central retinal occlusion patients are associated with open-angle glaucoma, and this is typically visible in the other eye, the uninvolved eye. So these patients typically present with sudden severe pain, conjunctival injection, corneal edema, rubiosis, closed angle, and poor vision. These eyes, when you see they're hot, injected, you'll have fresh blood in the anterior chamber, active rubiosis as is seen here, and the patient is in severe agony. So the best way to the number one thing that you want to do when a patient with neovascular glaucoma presents to your clinic is to control the pain, i.e., by controlling the intraocular pressure. In my hands, doing a valve, AMED valve, in combination with viscoelastic injection into the anterior chamber to prevent further bleeding, and Avastin injection into the vitreous cavity works the best. Some people believe in doing trabeculectomy. You do not want to do trabeculectomy in an acute setting of a neovascular glaucoma. This is ideal situation when a patient had PRP and the eye is in a chronic mode and quiet, and most of the rubiosis is resolved. But the patient is left with chronic angle closure. At that stage, you can attempt a trabeculectomy if you want. But doing a trabeculectomy in the acute presentation of neovascular glaucoma, I don't think is a wise idea, as it's prone with a lot of complications and early failure. Cyclocryo in a advanced patient with if a patient is blind and is in a painful situation secondary to neovascular glaucoma is an alternative that can be tried. If you do choose the cyclocryo pathway, you may want to extend the cryo to the retina, peripheral retina also, in order to control the VEGF production. So to shut down the VEGF production, you want to use the anti-VEGF medications such as Avastin in combination with PRP, and that controls the neovascular glaucoma episodes. Let's move on to eye syndrome or iridocorneal endothelial syndrome, the second situation where you have peripheral synechial formation or in the anterior pull mechanism, as can be seen in this example here. You can see this membrane that's pull the trabecular meshwork, pull the iris up and enclosing the angle structures. There is some combination of iris atrophy, corneal edema, and secondary angle closure glaucoma without pupillary block in these patients. So remember the combination of iris atrophy, corneal edema, and secondary angle closure glaucoma in the absence of pupillary block mechanism constitutes the iridocorneal endothelial syndrome. It's caused by an abnormal corneal endothelium that forms like a membrane across the iris, which when it contracts leads to iris distortion and angle closure, leading to glaucoma. So it's been depending upon which factor is more prevalent, more prominently displayed in the clinical setting. You classify the eyes into progressive iris atrophy, where predominantly you will see keratoopia and iris dissolution, Chandler syndrome, where you have corneal endothelial dysfunction and edema, along with glaucoma, Cogan-Reese syndrome or the iris-nevus syndrome, where you see pigmented lesions of iris, pedunculated or diffuse. But the common factor in all three of them is abnormal corneal endothelium. Here are some examples of eyes. Look at, in extreme cases, the amount of keratoopia that you see with iris atrophy. So demographics for the eyes are typically seen in 20 to 40-year-old, more common in females, more common in whites than Caucasian population compared to African American descent population, almost always unilateral, and it presents with iris or pupil distortion. This is the most common way that the patient, in my experience, notices that there's something wrong with their eye, and that leads to their presentation to the clinician. Vision disturbance because of corneal edema, mild ocular discomfort, maybe from elevated intraocular pressure. Now, here is a patient of mine that I treated 2 years ago. That goes against everything that I just said. This particular patient happened to be um, African American. She is, and she had bilateral eye syndrome, as can be seen in these two pictures. This is the right eye, and that's the left eye. Unfortunately, by the time this patient came to see me, she was blind in the left eye, so I didn't offer any treatment. Patient was in no discomfort, but for the right eye, I had to operate on her eye to control both the glaucoma and also do a DSEC to clear the cornea and take the underlying cataract out and reconstruct the pupil. She's doing well, by the way. So eyes can occasionally, rarely be bilateral, but for your practical purposes, remember it's almost always unilateral. It's more common in white population, more common in females. So what's the histology of this abnormal corneal endothelium? These are thin abnormal corneal endothelium and Descemet's membrane separated by a thick accumulation of collagen, which results in a multi-layered membrane that grows over the angle and the iris in creating the angle closure. The fundamental defect, remember, is an abnormal corneal endothelium. It's sporadic in nature. Differential diagnosis for eyes includes all of these disorders, posterior polymorphous corneal dystrophy being the most likely as the number one in the differential. Iridoschisis is another thing that you need to remember, and so is Axenfeld-Rieger syndrome. So treatment for glaucoma, obviously you want to try some aqueous suppressants. And if that doesn't work, you can either try a trab or a glaucoma drainage device. Either of those situations can work. ALT or SLT or YAG-PIs do not work in eye syndrome patients. As you can imagine, the reason why. Corneal edema, if the patient develops corneal edema, first thing you want to do is to control the intraocular pressure. And in spite of that, if the corneal edema persists, you may consider either a DSEC or a PKP, depending upon the stromal scoring. Most times, I had two patients that I did DSEC on, and they're doing great. So I think most people nowadays are doing DSEC. In the old days, we used to do PKP, or penetrating keratoplasty, on these patients. Let's move on to the third mechanism for today. Posterior push mechanism or malignant glaucoma. So we'll discuss some of this in detail and some briefly. Malignant glaucoma, as I mentioned at the very beginning, is the most complex and bizarre entity in this mechanism of angle closure glaucoma. And so is Nanophthalmos. These two are both are rare situations, but you got to be aware of these entities. Should you happen to see them in your clinic, you ought to be able to recognize them and offer treatment, or at least refer the patients to a specialist who can adequately treat them. The rest of these entities here, suprachoroidal hemorrhage, CRVO and PRP, retinal procedures like scleral buckle, gas in the vitreous, ROP and tumors and cysts, all of this we'll deal with in passing. So what is malignant glaucoma? It's also known as ciliary block glaucoma, cilio-vitreo-lenticular block, or aqueous misdirection syndrome. I think the BCSE textbook labels this as aqueous misdirection syndrome. So this entity was first described by von Graffe in 1869 as an uncommon complication of ocular surgery consisting of postoperative flat or shallow anterior chamber and elevated intraocular pressure, and coined the word malignant glaucoma as it responds poorly to conventional treatment. In those days, every single one of these patients ended up being blind. Even today, this is a difficult entity to treat, but fortunately, better understanding of pathophysiology has led us to better treatment options, and a lot of these episodes are resolved. But it's still a struggle. So this aqueous misdirection syndrome typically presents as I mentioned in the pathophysiology in the first few slides, with the shallow flat chamber, as is seen in this ultrasound, normal or increased intraocular pressure. The reason why initially the intraocular pressure could be normal is because a lot of these situations follow glaucoma filtration procedure. So in the presence of a functioning bulb, you have a flat chamber or a shallow chamber. The fluid is still getting drained into the bulb that you created. So the pressure gradually creeps up in this patient. So it's not an acute sudden episode of elevated intraocular pressure. Gradually, the intraocular pressure grows up, and it can initially be like 15 with a shallow chamber, to a week later to 20, and a month later it could be 30, and if left untreated, can go on to 40s and 50s millimeters of mercury. It responds to cycloplegics and gets worse when you use pilocarpine. Poor or adverse response to myotics usually follows glaucoma surgery, as I mentioned, in a patient with narrow angles in peripheral synechial formation and a hyperop. So if you have a hyperopic patient with narrow angles and synechial, peripheral synechial synechia that are present, um, take care not to anticipate malignant glaucoma. Take certain precautions. So, what precautions do you want to do? If you want to do a trabeculectomy in these patients, you want to use tight sutures. You don't want too much fluid to come out, and you wait for about a month or 2 months for the blood fibrosis to occur to some degree before you cut one suture at a time. The Especially in these kind of cases, if the patient is phakic, I am prone to taking out the underlying lens to create space in the anterior chamber in combination with the glaucoma surgery. It's foolish for us to leave that lens in this setup. Lens is not the direct cause, but I tell you, it does complicate the situations. So for me, taking the lens out works in a lot of these kind of patients, but it's not something that you're going to mention in your exams um, um, uh, unless as a last resort. So typically, as I mentioned, the sequence of events is that you do a glaucoma filtration procedure, you let some of the aqueous out. This leads to a flat anterior chamber or shallow anterior chamber. Intraocular pressure gradually increases from anywhere from 20 to 60 millimeters of mercury within a month or two. Patient should have a patent iridectomy. If the iridectomy is not performed or is not patent, you may want to do an iridectomy. And also, the patient should have a patent sclerostomy and in the absence of suprachoroidal hemorrhage or effusion. So that's how you make the diagnosis. So following glaucoma filtration procedure, if you have a shallow chamber with gradually increasing intraocular pressure in the presence of patent iridectomy and a flat retina, then you think of making a diagnosis of malignant glaucoma. Okay, can occur during surgery, immediately after surgery, when cycloplegics are discontinued, when myotic agents are added, or after considerable delay. If one eye has it, the second eye is at risk. Remember, now, we went through the pathophysiology of this to some degree. All of these mechanisms are associated with and complicate a malignant glaucoma situation. But most people agree that the anterior hyaloid face of the vitreous has a big role to play in this. A thickened and less permeable anterior hyaloid that is more anteriorly located, especially in the periphery, near the ciliary processes. Okay, so this anterior hyaloid in this area is when it moves forwards in response to shallow chamber or letting some of the aqueous out through the trabecular meshwork, through the blob that you created, will somehow close in the ciliary process, and the ciliary process, instead of producing aqueous into the posterior chamber, now starts hydrating the vitreous posteriorly, causing more vitreous hydration, and that in combination with um, choroidal volume increase could account for the sudden push mechanism that you see causing all the other sequence of events that we mentioned. So this schematic here explains the same thing. We have another video that was lecture that was given by Dr. Pradeep Ramalu from Johns Hopkins, and I thank him for doing that lecture. That should be also on our website. Delineating this pathophysiology of malignant glaucoma is much more elegantly than I'm doing here. So I urge you to take a look at that video too to understand this. So the differential diagnosis, suprachoroidal hemorrhage, suprachoroidal effusion, and pupillary block mechanism. Of course, if a patient has suprachoroidal hemorrhage, the patient typically presents with severe pain and with shallow chambers, and you examine the retina, you can see the dark swelling as is seen in this case is here. And on ultrasound, you can see blood in the suprachoroidal space, which is pretty classic. And the treatment for that obviously is initially for the first 7 to 10 days, control the intraocular pressure and some anti-inflammatory medications such as topical and oral prednisone and pain medications, and wait for the clot to melt before you drain it out, should you need to. Suprachoroidal effusion, on the other hand, can also present with shallow chambers, but there's no pain involved, and the pressure is typically low in this case. And if you look at the retina on indirect exam, you will see the effusion. There's no mistaking about it, and can be confirmed with a B scan. Pupillary block mechanism, on the other hand, is pretty classic. In the pupillary block mechanism, there are adhesions between the lens and the pupillary margin, as can be seen here. This is a case of occlusive pupil. And what happens is that the aqueous now, instead of cannot access beyond this occlusion, and so is accumulated behind the iris, causing iris Bombay situation where the iris is pushed forwards and closing the angle structures. In this situation, you can see that the depth of the anterior chamber centrally is maintained, whereas in angle closure glaucoma, the entire lens iris diaphragm is pushed anteriorly like this. Okay, so the entire chamber, both centrally and peripherally, is very shallow in malignant glaucoma, whereas in pupillary block mechanism, centrally the anterior chamber is still deep. Treatment: steroids to cut down the inflammation, cycloplegics to cause cycloplegia and consequently push the lens iris diaphragm posteriorly, which in turn will push the anterior hyaloid phase posteriorly, and glaucoma medications to control the intraocular pressure. If that doesn't work, the ultimate treatment obviously is to disrupt the anterior hyaloid phase, and this can be done with the help of YAG laser or the Chandler procedure, wherein you stick a needle and try and disrupt it. I don't think many people are doing this Chandler procedure anymore. If steroids and cycloplegia glaucoma medications and YAG laser does not help you, you may want to go for vitrectomy and lensectomy combination. You may want to make sure that you instruct your retina specialist to disrupt the anterior hyaloid phase, especially in the periphery. If you don't do that, the attack may not be broken, and the patient may still end up with a recurrent attack. And so these kind of cases, you got to make sure that you do a peripheral anterior vitrectomy to clear up that anterior hyaloid phase away from the ciliary processes. And once that's done, if the patient is phakic, you want to take out the lens, and anterior chamber deepening procedures added on top of this will resolve the attack in majority of the patients. If the attack does not resolve, in some of these patients, you may want to leave the chamber as uni chamber, meaning that the anterior chamber in combination with the posterior chamber to equalize the pressure and leave the patient aphakic. These are rare cases that need that kind of a treatment, but something to keep in the back of your mind. Some of these patients may need cycloplegic agents for the rest of their lives to keep the chamber deep and formed. I have 2 patients in my practice who are on cycloplegic agents to keep the chamber deep. Let's move on to Nanophthalmos. These are patients with nanophthalmos, by definition, have normal shape but small eyeballs. It can be of sporadic nature, autosomal dominant, autosomal recessive in inheritance. It's a bilateral condition, equally affects both males and females. These patients are usually high hyperopes, can develop angle closure glaucoma in the fifth or sixth decade as the lens thickens. As mentioned, small axial length and small corneal diameter with a normal, slightly larger lens, so that the lens eye volume ratio is 10 to 25% instead of 3 to 5%, predisposes these eyes to develop angle closure glaucoma as the patient ages. So the shallow chamber is both centrally and peripherally. Um, there is anteriorly displaced iris, high hyperopia. They also have thick sclera. There's one histopathology report that's been published where they showed that the sclera is twice the thickness of a normal sclera, and also in abnormal collagen pattern. Uh, these patients are associated with spontaneous or post-op uveal effusion syndromes. So you got to be careful, especially in the old days. They used to lose these eyes because of the big old incisions that they used to make, the 10 millimeter incisions to take the cataracts out. So, but it's nowadays with the small incision cataract surgeries, I've done several of these. The risk of complications is minimized. But when all said and done, these are special cases that you don't want to rush in to do any kind of surgical intervention. So the corneal diameter, here are some OCAP questions for you. Corneal diameter in these patients on an average is 10.3, axial length is 17. So anything below 18 millimeters or less is by definition nanophthalmos. Anterior chamber depth is 1.5 on average, as opposed to 3 millimeters in the normal eye. Refractive error plus 13.5 diopters, lens thickness 5.2 as opposed to 4.5 in a normal eye. Volume of lens versus eye volume, 12% as opposed to 3% or 4% in the normal eye. And combined scleral choroidal thickness is more. So when you see it, you want to recognize this condition. Regular IOP checks and gonioscopy in these patients as they grow older. The angle is going to get more crowded. It can lead to increase in intraocular pressure. So when that happens, aqueous suppressants, so the treatment of choice, PI or peripheral iridotomy and laser iridoplasty are safest procedures to do with least complications. But if surgery is essential, the first thing that you want to do is to do a small incision cataract surgery to decompress the chamber. Once it's done, along with the goniosinic lysis, once it's done, a lot of these cases, the intraocular pressure could be controlled with the help of glaucoma medications. That's what I've been doing in the last three cases that I had in my practice, and patients are quite happy with no complications associated with it. In the old days, we used to do leave the lens alone and do a trabeculectomy procedure, and I believe that's where most of the complications came in. But I strongly believe that the way to handle these cases is to do a lens removal with small incision cataract surgery combined with maybe plus or minus a deep sclerectomy, non-penetrating glaucoma surgery, or if you choose to do a trab with tight sutures. I will do this in two stages if I have to. But having said that, from your board's point of view, the question that they're likely to ask you is, what do you expect if you do a glaucoma filtration procedure in these eyes? Uveal effusions, and the way to avoid the uveal effusions is scleral window creation prior to surgery. Remember that. Let's move on to drugs that can induce secondary angle closure glaucoma. The Topamax, the topiramate, and other sulfa-based drugs can idiosyncratically cause ciliary body swelling or ciliochoroidal effusions and zonular relaxation, leading to anterior displacement of the lens iris complex. And these patients present typically with bilateral angle closure glaucoma and high myopia. Treatment obviously is to discontinue the meds and the inciting meds, that is, and aqueous suppressants and cycloplegic agents, both to control the intraocular pressure acutely and deepen the anterior chamber. Usually, glaucoma resolves in 48 hours and myopia over a period of 2 weeks. If it does not and the pressures continue to be too high, you may try a laser, organ laser peripheral iridoplasty to peel the iris away from the angle structures. As soon as you open the angle structures with iridoplasty, the pressure drops down in a dramatic fashion. So I conclude my lecture with some high yield material for the sake of my residents. I am so good, I know. Angle closure in Plateau iris is most often caused by anteriorly positioned ciliary processes. Diagnosis of Plateau iris can be made only by gonioscopy or by other angle imaging techniques. Okay, suspect Plateau iris when anterior chamber is deep centrally with flat iris plane in an eye with angle closure. Peripheral anterior synechia begins at the Schwalbe's line and extends posteriorly to scleral spur and angle recess in Plateau iris, while a reverse is seen in pupillary block induced angle closure, where PS is formed posterior to anterior direction. Diabetes is the most common ocular vascular disease to cause neovascular glaucoma, while carotid occlusive disease is the most common systemic vascular disease. Peripheral anterior synechia in neovascular glaucoma ends at the Schwalbe's line as opposed to ice syndrome where it rides more into cornea. Avastin causes regression of the iris new vessels but may not control intraocular pressure if the angle is closed with peripheral anterior synechia formation. Abnormal corneal endothelium is seen in all three clinical variants of ICE syndrome. ICE is characterized by abnormal corneal endothelium, iris atrophy, angle closure glaucoma, and corneal edema. Chandler syndrome is the most common form with prominent corneal and angle abnormalities and minimal iris changes. ALT or organ laser trabeculoplasty and miotics such as pilocarpine are not effective in ICE syndrome glaucoma treatment. Aqueous suppressants are the medical treatment of choice in ICE. Prostaglandin analogs may not work effectively in ICE syndrome. Ocular inflammation causes inferior peripheral anterior synechial formation most frequently, while primary angle closure cause PS starts in the superior angles preferentially. Aqueous misdirection is associated with flat chambers, both centrally and in the periphery, and elevated IOP. Aqueous misdirection is associated with anterior rotation of the ciliary process and posterior misdirection of the aqueous. Miotics should be avoided in aqueous misdirection, while cycloplegics and aqueous suppressants are the mainstay. Definitive treatment of aqueous misdirection is vitrectomy with antihyaloid disruption combined with anterior chamber deepening procedures. Angle closure secondary to anterior choroidal effusion, anterior rotation of ciliary body is the mechanism underlying scleral buckle, central retinal vein occlusion, panretinal photocoagulation, topiramate, and other sulfa-based medication-induced angle closure glaucomas. All these situations, its angle closure is secondary to anterior effusions and anterior rotation of the ciliary body. Intravitreal gas or silicon oil can induce angle closure. Because these are less dense than water, they raise to the top. You want to do an inferior PI to avoid obstruction. Persistent fetal vasculature is associated with microophthalmos and elongated ciliary processes. Contracture of the hyperplastic primary vitreous and swelling of the lens leads to angle closure glaucoma. So hypotony with flat AC following cataract surgery, you have to rule out a wound leak. AC deformation immediately if anterior hyaloid or IOL cornea touch, meaning that if the patient is aphakic and there's vitreous coming into the anterior chamber and touching the cornea, or the intraocular lens is in contact with the cornea, or in the presence of corneal edema, excessive inflammation, or posterior synechial formation, you want to reform the antechamber. immediately. This is in the setting of cataract surgery in the immediate post-op period. A PI is not indicated in Topomax or sulfur-induced angle closure glaucoma. That concludes our lecture for today. Look out for more lectures on MediTred YouTube website. As always, I thank you for your patience, and please look out for our upcoming CME and board review courses. And should you have any comments, send me an email at ayala@meditred.com or at rayala@tulane.edu. Thank you.